So this is a little webinar we do about relaunching, as I said, ahead of the flu season or the winter. And we thought it would be a great opportunity for those who are involved in the trial already, but also for the new members to meet the whole team. I'll show you who they are. Unfortunately, we've had a little bit of illness amongst the team, so not everybody can join today. We'll go through the trial, the background, the individual domains, the sort of interventions we're testing for flu. We'll go through that in a bit more detail. And then we thought it would be useful to highlight some of the work we've been doing behind the scenes, with including a new website where all the information about the trial is and how you can download that. Again, making life easier for you at sites. We're piloting an electronic site file, and hopefully that will help, and including things like archiving amendments, which for a platform trial, as you'll see, these build up over time, and we're learning all the time how to run these trials. And so again, information about these sort of logistics issues, which are very important. And then finally, sort of an update on ongoing processes, how we'll try and help support you over your recruitment over these coming months. So just to remind you, REMAP CAP is an international trial, and we're very proud of the fact that we are recruiting now in every single continent around the world, apart from Antarctica. And it has grown massively over recent years. And you can see there are multiple sponsors in different regions around the world. And obviously in the UK, we are still part of geographical Europe, and our sponsor is UMC Utrecht. And again, just so you're aware of the logistics of that, therefore in the EU, the overall lead is Lenny Durdy, an intensivist and infectious diseases specialist at Utrecht, and along with Mark Bonton, an ID specialist. And I'm the UK lead, and Imperial are working with ICNARC as we deliver the trial in the UK. And you can see the team we have here, different trial managers and monitors, data managers, and so on. And so hopefully you'll actually meet some of these people. Now we're starting to be able to come out to sites. You'll see us, obviously see some on the webinars, but you'll probably get emails from a number of the different people. And it was just under a year ago, as you'll see, December 2022, when we got the go-ahead from the NIHR, when we were selected as the NIHR's platform trial to investigate interventions for influenza. And importantly, we wanted to realize that with this funding, what we were tasked to do was test influenza interventions, not just in the ICU, but in the whole hospital, not just adults and children as well. So we put together a proper multidisciplinary team. So not just intensivists, but we've added ID and virology experts, pediatricians, respiratory physicians, general physicians to join this group. And so representing the whole of the UK, including the devolved nations. So we've got Scottish and Northern Irish representatives on the group as well. And so very much we want to bring this team together to tackle influenza, because it's actually, as the NIHR would put it, it's about pathway research. Influenza, actually, these patients come in through the emergency department. They're often on acute medical wards. ID teams are involved in selecting treatments. Some of the sicker patients will come through to critical care units. And so we really do need a multidisciplinary approach. And it's one of the challenges of delivering it, but hopefully we can do that. And so just remind you, REMAP CAP has been around for a while now. It was set up after the H1N1 pandemics, 2009-10, realizing we needed different ways to do our research. And so it's an international platform, adaptive platform for severely ill patients with community-acquired pneumonia that could be applied both into pandemic and during pandemics to reduce mortality, ICU use, and morbidity in the more severely ill patients with community-acquired pneumonia. And what do we mean by an adaptive platform trial? Well, I hopefully try to capture the essence of that in this figure here. And what the platform is done is set up to tackle a disease area. So in this case, community-acquired pneumonia. And that's sort of shown by the outer blue line that you see. So it's a platform that wants to recruit patients who have that disease, in this case, community-acquired pneumonia. We have very simple criteria. Are you eligible to be included in the overall platform? Then within the platform, we have what we call different domains, and these are sort of areas of intervention where each domain almost could be thought of as its own little trial that takes part in the overall platform. And the advantage to this is that you can share the resources, the logistics of the platform to run several interventions at the same time. Patients may be eligible for one or more interventions at the same time, and so you can get more information with fewer recruits, and potentially even look for interactions between treatments. And each individual domain may have its specific inclusion-exclusion criteria as well, so you can select the right patients for the right interventions. But is that, so if you take this picture, that helps explain the overall structure of REMAP CAP. You come into the platform, you get randomized to one or more interventions that you may be eligible for, and we share the outcomes and the resources to get answers more quickly. And that's how we started. Pre-pandemic, we were studying bacterial community-acquired pneumonia, questions around which antibiotics to give, how long to give macrolides for. And then obviously with COVID-19, we had to add this group of patients. We had to make some changes to the overall platform because COVID was different, as we're all aware, to more standard bacterial pneumonias. But I think it was a great success. The platform trials showed their worth. And you can see here a forest plot of our interventions to date, 13 that we've reported on, showing the benefit of some drugs, particularly the steroids and the IL-6 receptor antagonists, tocilizumab, sarilumab, that many treatments we thought might be beneficial, convalescent plasma, for instance, in an unselected population isn't helpful. And even, of course, importantly, interventions that actually maybe look harmful. Think of the hydroxychloroquine, Kaletra, and more recently ACE and ARBs, which people thought because of the SARS-CoV-2 virus may be useful, actually looked like they were harmful. And we will be reporting 2 more interventions coming out later this month. And so part of that success, I think, in getting answers out quickly from REMAP CAP, and what makes it exciting is using innovative, novel trial design, and particularly we use a Bayesian model. I won't go into too much detail of stats now. No one wants to spend the afternoon having too much detail on the statistics. But I think the key factors to mention is that compared to a more traditional A versus B trial in a frequentist design, we don't have any fixed sample size. So those other trials, you would power it based on the event rate, how big a treatment effect you might expect, and so on. Whereas the Bayesian approach takes differently. So it says, what do we know already? Let's generate that high quality data through randomization, in this case, and update our evidence and our probabilities. And you can set your probabilities, and we're interested to know, are drugs effective? Or are they ineffective, for instance? And we just keep on enrolling until we hit a predefined threshold to say something is working or it's not working. So to illustrate that in just a simple design, if we take the effect here on this plot and we say the odds ratio of 1 means that the drug has no effect. What we do with Bayesian is we start with a neutral prior. What do we know already? We say, well, we don't know if the drug works. It's so we're sent to the effect or no effect, and you can see the likely distribution of effects could be beneficial, could be harmful, but it's very weak evidence. As we gain evidence and run various adaptive analysis, which are all blinded to investigators, so we don't know this when it's going on, but this happens in the background. You just start to generate evidence from the patients enrolled in the trial, and you start to update the likelihood that the drug might work, for instance. So here in this case, we're saying we've got some evidence now that maybe this drug is beneficial, and odds ratio here we're saying above 1 is beneficial. But you keep on going, there's still a lot of uncertainty. You gain more data, you update the probabilities that the drug might work, and you can see getting stronger evidence until finally you get clear evidence. In this case, what we're saying is there's more than a 99% probability that this drug is improving outcomes compared to the control, in which case we would stop and report the results. As you can see from this sort of figure, hopefully explains, if you have a big treatment effect, you will stop early because you'll be certain the drug is better than the standard of care very quickly. If it's a smaller effect, you'll need larger numbers to get that definitive answer. And so this is the approach we use in REMAP CAP. And so now taking this from COVID, as we said, we're now tackling influenza, and we have these pathogen strata. So they're almost like subgroups, but accepting that these infections are not all the same, we analyze the patients according to the likely cause of their infection. So with influenza, as well as having the various pathogen strata, we also have, except that our patients are all different. We've expanded from just adults and now are including children as well. And we've split the children into sort of two different strata, above and below 12 years of age. And just to explain with the Bayesian models as well, these are separate subgroups, essentially. But with the whole modeling, it's what they call a hierarchical model. You can actually borrow information between these groups because they're not separate groups. A 12-year-old and an 11-year-old are not entirely separate. There are going to be commonalities between them, and similarly between adults and children. And if we learn that the information is very similar across these different strata, you can borrow that information to help inform the analysis in the different groups. If they're very different, then that borrowing is less. So we have the best of both worlds. We can report on subgroups, but we can use these techniques to learn from it. And I think this is particularly useful for children, where it can be hard to get enough data to support whether drugs are effective only in children compared to adults. And hopefully this approach will give us answers that will help inform pediatric care as well as adult care. We also accept that drug effects may depend on how severely ill the patient is. And so again, we have different, what we call them disease states here, but they're essentially, again, subgroups. Are you in the severe disease state, i.e. critically ill, and what we define that is in the ICU receiving respiratory or cardiovascular organ support, or all other patients we say are non-critically ill, they're in moderate state, and those are the patients either on the ward or who are in ICU and not receiving organ support. I know that's a rarity in the UK. And again, information can be shared between these groups if actually the drug is having a similar effect in these two different disease states. And so we have these different pathogen strata. And what are we studying in influenza? Well, obviously we have an antiviral domain, which is looking at oseltamivir, which has been around for a long time. Baloxavir, which is a newer influenza antiviral that works in a different way. And also we're testing when maybe these antivirals are best in combination. So actually testing the combination as well. And we're comparing that to a control because, as you'll hear from in a bit more detail in a moment, we actually have brought these drugs in without evidence that they improve outcomes in hospitalized patients. And so we think it's important to randomize against control because maybe these drugs are ineffective. And of course, although we think they're relatively safe, we never know if there could be a harm signal if they're not actually effective. We're also testing whether steroids work. We've seen evidence in COVID clearly of their effectiveness, and there's been a lot of debate for years about the role of steroids in influenza, and evidence from RCTs is sort of generally been lacking. So we've used observational data, and so we're testing dexamethasone versus control. For those in ICU only, we would been testing hydrocortisone for other bacterial community-acquired pneumonias pre-pandemic, and so that continues on the ICU only. On the ward, we're just testing dexamethasone versus control. And then we learnt in COVID-19, again, the role of immune modulation therapy, tocilizumab and baricitinib, so IL-6 receptor antagonist and a JAK inhibitor, both again shown to be beneficial for more severely ill patients. Do they have a role in influenza, where we know that there again is a lot of information in the sickest patients. So that's what we are studying. And go through who's eligible for the study. What I do is, first of all, go back to that figure I showed you about the platform and say we have the platform eligibility criteria. So do you come in that overall blue line that we showed on the outside? And again, you'll see that the inclusion criteria are very general. It's now, are you an adult or pediatric patient? We're going down to 28 days or older, so excluding neonates, and that's corrected gestational age. So for premature babies, waiting till they've got past their 28 days correction gestational age. Are you in hospital, anywhere in the hospital, the ward or the ICU? And are you there because of acute illness due to respiratory tract infection? So as you see, very broad inclusion of who's in the overall platform. The exclusions, we've tried to have very few. Just that you've not been in hospital for more than 14 days. Again, I think if you've been in hospital a long time and you develop flu, you're probably a very different patient to the ones getting it in the community. For those who are critically ill and in the ICU, you have to be included within 48 hours. Again, we think the interventions are likely to work early in acute illness. And so therefore, we don't want to say they're ineffective, but just because we're giving them late. So you have, if you're coming into the platform in the ICU, you have to be within 48 hours. And then we're excluding people at both ends of the disease spectrum. So if you're actually already too sick and death is imminent and you're sort of not having full resuscitation, etc., and you're expected to die within the next 24 hours, you are excluded. And as I said, at the other end of the spectrum, if you're already cured and about to go home, so if you're expected to go home in the next 24 hours, again, we can't make you any better than you're probably already doing. So again, we would exclude both of these extremes. And obviously, you can only come into the trial once in the primary outcome period over the 90 days. So very simple criteria of who's eligible for the platform and who's not. So I thought it'd be useful then to go into a little bit more detail about the domain backgrounds. And we've actually got some investigators from around the world, pre-recorded videos to try and explain a bit of the rationale for these domains. So I'm hoping this is going to work.
Hi, my name is Srinivas Murthy. I'm excited to talk to you about influenza antiviral strategies within REMAP CAP. I'm in Vancouver, Canada. I'm a critical care and infectious diseases doctor. I primarily practice in pediatrics. So I'm only going to take a few minutes. Randomized evidence for influenza antivirals in hospitalized patients. I would love for there to be any. Unfortunately, there are no fully enrolled prospective randomized trials of one of the most commonly used medications on the planet, oral oseltamivir, for hospitalized influenza patients. And so it is the year 2023. We've been using this medication for decades, and we do not have any randomized evidence for its benefit. And that's the gap that we're aiming to fill. So previously, and over the past couple of years, we've been enrolling patients with suspected or proven influenza to one of no antiviral, 5 days of oseltamivir, or 10 days of oseltamivir. We've got about 200 randomized in that domain thus far, with a primary outcome of 90-day mortality. Over the past year or so, we've amended this domain. This is what's currently active to patients with proven influenza only. Namely, you need to have a positive test, and incorporating a new medication, baloxavir, that's approved most countries around the world for the treatment of less complicated influenza. Randomized, so the patients will be randomized to one of no antiviral, 5 or 10 days of oseltamivir, and baloxavir, and then baloxavir in combination with 5 or 10 days of oseltamivir. These arms have been added, and patients are beginning to be recruited to these interventions around the world. The inclusion criteria are now patients with confirmed influenza infection, and that confirmation can be with any locally approved diagnostic test, and age greater than 28 days old. And so now we've included children in this domain. The exclusion criteria are more than 96 hours since hospital admission or more than 48 hours since ICU admission. The original intent of this domain was to focus on community-acquired infections. If you've already received 2 or more doses of oseltamivir or 1 dose of baloxavir, you're excluded. If there's a clinical decision by the clinical team that they really want to treat with an antiviral, then obviously they won't be eligible to participate. And for the baloxavir-containing interventions, pregnancy is a specific exclusion, given the lack of available data for safety. The baloxavir dosing regimen is as you see it. For adults, it's 40 milligrams on day 1 and 4, plus day 7 if the clinicians think that it's clinically indicated, i.e. the patient's not getting better. The oseltamivir dosing is for adults 75 milligrams twice daily for the duration of which they're randomized to. Children and renal dysfunction, we provide dosing recommendations, although if there are local guidelines that inform that, we aim to be pragmatic and abide by those guidelines. For pediatrics, and one of the novel aspects of this domain is that we are including both kids and adults for a common disease that affects both children and adults. And we're incorporating novel statistical techniques to learn as much as possible about the benefit or harm in children using adult data that's generated during the trial. So hopefully we'll have some child-specific evidence that can inform child-specific practice from this large international platform. And as always, I do always want to emphasize the global and collaborative nature of REMAP CAP. We have sites on every continent and patients recruited from every continent, and we're excited to continue to engage with the larger community. Thanks.
Okay, so there's an overview of the influenza antiviral domain, and what I'll do now, before we then open to questions, is show our similar video about corticosteroids.
Hi, my name's Derek Angus. I am the chair of the corticosteroid domain for REMAP CAP, and I'd like to just briefly go over some changes to this domain. By way of background, REMAP CAP is addressing, broadly speaking, the question of whether corticosteroids help patients hospitalized with severe community-acquired pneumonia. This remains a question for which the answers are unclear. We have demonstrated benefit in severe COVID-19, but it's not exactly sure if there would be benefit in other types of CAP. There have been numerous randomized controlled trials and meta-analyses, but these results have been inconclusive. Some suggest benefit tending to be in sicker patients, but there are also adverse effects. And so some of the key unknowns that REMAP CAP was already designed to address include, should steroids be given for CAP due to influenza? How should dosing of steroids be given if the patient also has concomitant septic shock? And what to do if the patient has not just CAP, but also ARDS? But there are 3 other questions that we would like to embrace in the design. One is, which corticosteroid should actually be used? There's evidence for benefit with both hydrocortisone and with dexamethasone. It's also unclear whether corticosteroids should be given to children with severe CAP, severe influenza. And it's also unclear what to do if the patient is sick and admitted to the hospital, but not so sick they're admitted to the ICU and meeting the severe state criteria. And so we've implemented 3 changes to the corticosteroid domain. First, we've added a new intervention, fixed course dexamethasone. Second, where sites have got approval for the updated core protocol, the domain can now be open for patients in moderate state, i.e. patients who are not receiving organ failure support in an ICU at the time of enrollment. And third, we've extended the age limit down to 28 days. In other words, children, other than neonates, are now eligible for enrollment in REMAP CAP. So the changes to the inclusion criteria are children from the age of 28 up through all of adult life. And if enrolling patients in the moderate state, there is one proviso, which is that they should not only be hospitalized, but they must be receiving some form of supplemental oxygen by face mask, low or high flow non-invasive ventilation, for example. The exclusion criteria remain essentially unchanged: known hypersensitivity to any corticosteroid, intention to prescribe systemic corticosteroids for a reason other than CAP. For the severe state patients, if they've already been admitted to the ICU for more than 24 hours, and if the clinical team believes that participation in this domain is not in the patient's best interest. In terms of something about these arms, so there's now essentially 4 arms that someone can be randomized to: the no corticosteroid arm, the fixed dose hydrocortisone, which is a 1-week course of IV hydrocortisone at 50 milligrams Q6. Also the shock dependent hydrocortisone, which is IV hydrocortisone also at 50 milligrams Q6, but only while the patient is in shock. These doses, these arms all existed before, and now this new arm of fixed duration dexamethasone, which is IV or enteral dexamethasone at 6 milligrams daily for 10 days, but with dose adjustment for pregnancy, and also in children, it is weight-based dosing. As always, if you have any questions, you can reach us at www.remapcap.org. Thanks so much. Hi.
So just before we go to questions, just to confirm for the antiviral inclusion criteria, we do now need patients to be confirmed influenza positive. Pre-pandemic, when testing wasn't so available, we did say suspicion of influenza, but we think now with more rapid testing being widely used throughout the NHS, we need to know that the patient's confirmed influenza positive by any means you happen to use. And again, the exclusion criteria, there's some time limits there. Again, trying to treat people early. So 96 hours of hospital admission or 48 hours from ICU admission. If they've already been treated with an antiviral, we've said 2 doses of oseltamivir or 1 dose of baloxavir because it has a longer half-life. They've already been treated. We're not going to learn by randomizing these patients whether they're effective or not, so they would be excluded. And you heard, we're keen to include pregnant patients. They can be randomized to the oseltamivir interventions versus control, but not to the baloxavir. So they can still come into the domain, and the system is set up that we ask if the patient is pregnant, and it would leave baloxavir off the randomization options if it was a pregnant patient we were including. And for the steroid domain, again, very simple, just slightly sicker patients. They just need to have some form of supplemental oxygen. Again, the evidence from COVID suggesting if you didn't need oxygen, presumably without a pneumonitis, without inflammation, you're unlikely to benefit from the steroids. But just any form of any level of oxygen, they're eligible for the steroid randomization. For ICU only, again, that early critical illness within the first 24 hours. And obviously, if they're already on steroids for another condition, or you need to give them steroids, they can't be randomized. And then just to mention, we don't have it open right now, but just to warn you what's coming up over the winter, as I mentioned, we will be studying the immune modulation tocilizumab and baricitinib. Again, has to be confirmed influenza cases and only for the critically ill patients, so the sicker patients. And if they're already immune suppressed, particularly neutropenic, if you are thought to have an active TB or invasive fungal disease, again, we wouldn't want to give them immune suppressants. Or if they're already receiving the drugs, then they couldn't be included. But hopefully, again, very simple criteria so that we can make it easy for recruitment and get large numbers up. To start the influenza interventions, you do need to have amendments 37 and 38 approved at your site, and selected the interventions that you are going to study. We can maybe discuss that in the Q&A. Not every site has to do it every domain, and you don't have to do every intervention, for instance. We would encourage people to try and do as many interventions as you can. For instance, so that we learn the most information. But I know, as we discussed yesterday, some sites, for instance, had felt they couldn't in ICU patients not give steroids if they were in shock. And so you could choose then not to have the control group and just compare the fixed dose steroids versus shock only steroids. Some people have asked about not giving antivirals at all for these patients. In the antiviral domain, is it right that we've got a control group? We've got support from the literature, so as we've heard, there's no proven benefit of these drugs in these sicker group of patients. Chris Whitty wrote a letter last year, which we've put on our website, encouraging physicians to randomize the patients so we can learn whether these drugs are effective or not. But if you felt in your site you can't not give an antiviral, you could compare the different doses of the different durations of oseltamivir versus the baloxavir and the combination. So again, you could do that. You can still randomize patients. You can still contribute to the learning about these interventions. We do need training logs completed for the version 3.1, which is the core protocol, and then the domains that are open. And I know it's difficult getting the training done, but it is crucial. We're going through an MHRA inspection at the moment of what we did during the COVID. And it's quite clear they do need to see training logs. Obviously, it was a very difficult time during the pandemic, but certainly we need to ensure staff are adequately trained on the protocol. And what we're trying to do is make that training relevant for your role so we don't overload people. Just to explain the drugs, the oseltamivir and dexamethasone and the hydrocortisone, you would just use your normal hospital stock. It's all open label, and you can use those standard drugs which you will have in your hospital already. We recognize you may not have baloxavir, and so that's been donated to the trial by Roche. We're very grateful to them. And we've got order forms that we can send out to you, you can order it in once the domain is active at your site. And of course, as you heard, if you've got any questions, probably better to email the UK team, so UK REMAP cap at ignarc.org. And one of the team can answer specific questions that you might have. Just mention, just briefly, that we're concentrating on influenza now, flu, but if any sites are interested in any of the other interventions, particularly about antibiotics and macrolides in the ICU, and cysteamine, and anticoagulation, whether it's better to give this intermediate dose thromboprophylaxis, you're very welcome to join those. And specifically, just mentioning it amongst immunocompromised patients, which I think are the biggest group that we're seeing of COVID now in hospital. Some evidence from our previous analysis that although convalescent plasma doesn't work in all comers, amongst the immunosuppressed, it may be beneficial. And particularly now that we have convalescent plasma in vaccinated patients, you get really high titer levels. And importantly, it still works against new variants, unlike the monoclonal antibodies. So again, if you're interested in that, let us know. And this would be immunosuppressed patients only, but for those of you who may work in transplant centers or have big hem-onc centers and so on, you may get these patients. And I think this is a potentially useful treatment for them, but we need to show that in an RCT. So let us know if you want to join. And now let's move to some of the logistics issues and so on, and go through the consent process, which is important. Liz, are you going to present this?
Yeah. Hello, everyone. So in line with our recent MHRA inspection, we just wanted to highlight the consent process to all our sites. So first of all, we just wanted to let everyone know that if the patient does have the capacity, informed consent must be obtained prior to randomization. In the event that a patient doesn't have capacity, we do have deferred consent in place, and we do ask that you seek personal legal representative consent first, and then pro LR if the per LR is not available. If the patient doesn't have capacity and neither the Perla or Perla is available, REMAP CAP is approved for delayed consent, which allows us to randomize the patient prior to obtaining consent. If delayed consent is used, consent from the patient or Perla or Perla must be obtained as soon as possible. And if the patient regains capacity, retrospective consent must be obtained. Discussions must be held with the patient or Perla, so family member, prior to discharge, and this must be documented in the medical notes. And the patient and the family must be aware of the patient's participation before they are discharged from the hospital. Next slide, please. Again, this is just highlighting the consent process in adults lacking capacity. So as said previously, if a patient is identified as being eligible for the study, their capacity should first be assessed. If they don't have capacity, we would like you to check with whether the Perla is available. If yes, then you'd obtain Perla consent before randomizing the patient. If there is no family member available, then you check if there was a professional legal representative available. If yes, you'd randomize and then obtain Perla or retrospective consent thereafter. If there is no Perla available, then you'd randomize and then seek to obtain Perla or Perla as soon as possible. And again, we just want to highlight that it should always be documented in the patient notes, any conversations regarding consent, and if necessary, a file note should be placed in the ISF. If it's not written down, it didn't happen, and all patients and families must be aware of their inclusion in the study. So in order to help with the process of consent, as part of Amendment 38, we had a consent animation approved, and we'd just like to play that for you and explain the process of how to use the animation after.
Yeah, so I'll play the video in a second just to explain that what we think is useful is to help patients when they may not have the capacity to read a long document but still be informed about it. We put this video together which, as I said, the REC have approved, so I'll play it now for you to see.
Research is how healthcare professionals find out the best way to treat illnesses or health conditions. Most hospitals and many healthcare professionals are involved with research. It's an everyday part of what we do. GPs, doctors, nurses, physiotherapists, pharmacists. Everyone wants to make the care better for people who need it. All research is looked at by an independent research ethics committee who check that it is okay for people to take part in. Taking part in research may or may not help the person taking part, but it will help healthcare professionals learn more about the best treatments of people who have the same illness or condition. We will only ask you if you would like to take part in research if your doctor says it is okay for you to take part. A research nurse will talk to you about the research and you can ask questions about it. If you say yes or no, it will not make a difference to the care you receive. You will still be looked after by your healthcare team. If you say yes, you will be asked to sign a form called a consent form to show that you want to take part in this research. Even after you've signed the consent form, you can still change your mind and say you no longer want to be part of this research. Sometimes people are too ill or not able to understand the research to say yes or no. Then someone close to them, a family member or friend, will be asked if they think that the person would like to take part in research. If there is no friend or family member able to talk to the research nurse, then an independent doctor who is not part of the research study is asked to say yes or no. As soon as the patient is well enough and is able to understand the research later on, they'll be asked if they want to stay in the research study, and they can say yes or no. This video is about a research trial called REMAP CAP. This research trial is happening in 150 hospitals in the UK and in more than 300 hospitals around the world. It is looking at which medicines will most help people when they're in hospital for pneumonia, flu, or COVID-19. Research has already given us some information about what might help treat people who are in hospitals with lung infections, flu, or COVID-19. but we need to know more, especially as new medicines have become available. This research is called a platform trial. This means that several different medicines can be tested at the same time, and we can find out which ones work best and stop using the ones that aren't helping people with lung infections. New treatments can also be added. If you join this research, a computer will select one or more treatments for you. This is called randomization and means people are put in a group by chance, which allows us to compare different treatment groups. Are you ready to make treatment better for people with lung infections? Speak to a research nurse to find out more. If you agree to being part of this research, you'll be asked to sign a consent form and given a copy of it along with a privacy notice.
So as Tony mentioned earlier, this would be for patients who aren't fully able to digest the patient information sheet. So we'd expect them to watch the video and then they'd be given a video consent form which they can sign, but they would still need to be given the full PIS, which contains all the interventions for the study, and they can keep that for their records, but they wouldn't need to sign that as well. As signatures of the video consent form would be sufficient.
Thanks, Liz. Yeah, so we hope this is the right approach. We've worked with the ethics committee, and interestingly, we're talking to patient representatives a lot. They're saying, we want to know about the study, but reading detailed consent forms is challenging. So this is what the video is there. It's got most of the information in. Obviously, it doesn't have all of the specifics of the interventions, but they're listed in the patient information sheet, including side effects. So it's important you give them the information sheet as well so they can see that. But we thought this is a good way to help sort of introduce research to patients and maybe relatives as well. And that's on our website. And what we'll probably do is set it up as a QR code so you could scan it with your phone and get a direct link if people want to look at it on phones or tablets.
As part of the relaunch, we've also developed a new website, and we've taken a lot of feedback from our current sites. And one of the things that we did do was separate the pages for the different teams. So there's a specific ICU page, a ward page, and a pediatrics page. There's also training videos, and there'll be things such as the SIV uploaded onto there, which will be coming soon. The training logs have also been uploaded, as well as the materials. And this is a lot easier to find, and it's a lot easier to look at which materials are relevant for the domain that you wish to open. We are also introducing to the new website a new segment called REMAP Bites. So these are bite-sized videos that you can watch to refresh your knowledge on some of the different domains and topics that you may find difficult within REMAP CAP. As you've just seen, the consent animation will also be on the website, and so will the newsletters for the UK and the global newsletters as well. And we also have our documents tracker uploaded onto the website as well. So what I'll do now is I'll just take you to. So this is our new and improved REMAP CAP website. So this is the homepage, and on the homepage on the left-hand side, you've got recruitment information, and on the right-hand side, you have tabs for the different teams, ICU, wards, and pediatrics. You also have a video about the study at the bottom, and then some general information again about the study right at the bottom of the page. Then at the top of the page, we have our menu bar. So we have tabs for sites, patients, our documentation, publication, media, and contacts. So I'll first talk you through the sites tab. So again, there's some general information on the study, and then again the pages for the different teams. So on each page, it will show you which domains are open to that team. So if we go into wards, you can see here some information just on the study, and then here you can click this link that will take you to the randomizing database Spinnaker, and below you can see all the domains that are open to the ward teams, and it will tell you whether they are for CAP or flu patients or pandemic patients. And clicking on these icons here will take you straight to the training information that is required for you to complete in order for you to be set up to that domain. So on the patients tab, we just have some lay information about the study for patients, and they can also download the privacy notice from here. Then we have our new documentation tab, which I mentioned earlier. And here we've divided the documents into 10 folders. So in protocols, you have your domain-specific appendices and all your domain choice pages. And then we have a local information pack for sites that are new and looking to set up. And then again, this is our training folder. So clicking in here will take you to the adults, pediatrics, folders, and then you have the domain slides and training logs for all of the domains in REMAP CAP. But going into, for example, adults, will take you to the specific folder for the domain, and in there are your training logs and all your training materials. So it's a lot easier to complete training now. And then if we go back, we have our consent folder. We showed you the consent animation earlier. So in this folder, you can find that animation, and all the PIS documents and consent forms are in here too. And also leaflets and posters are also in this folder. Again, going back to the documentation page, so we also have another folder for amendments. So all amendment documentation can be found in here, including our amendments tracker. And we also have a new folder called study tools, and these are just a few documents that we thought would be helpful to sites. So some of the calculations that are required, delegation log, again the leaflets and the posters if you want to put this up around site, and also a document version tracker which just shows you what the most recent documents you should be using within the study. We also have a pharmacy folder which contains the pharmacy guide and also all the admin guides. And then we have our newsletters folder, which has been divided into the UK and global sections, and you can obtain them just for general information about the study, and it will also have the latest news about the study in those two. Some feedback we received from sites was that they would like to access superseded documents. So we've created a folder for this where you can access old consent forms, old protocols, just in case you need to refer to these. And then the last, not least, folder is our FAQs. So if you have a question, it may have been asked before and you may be able to find it in one of the FAQ documents. Then our media, just to show you what this looks like. So we have our events page, which is brand new. So this will tell you what the latest event is within REMAP CAP, and it will also be here in a blue banner, and if you click it, it will take you straight to the domain page. And if you do happen to miss an event, we hope to record these and also place this on the websites for those who could not attend. And then we have, as mentioned before, our REMAP Bytes page, which will be short videos that you can watch to refresh your knowledge on REMAP CAP. And if you have any suggestions, please do let us know, as we do want to take on board site feedback and make the study as simple as possible for you all. And again, we have our Q&A tab. So we will be having monthly Q&A sessions, and this will be discussed further through the presentation. And as mentioned earlier, we have our contact page if you're ever looking for our email address, and clicking this tab will open your email app, and you should be able to send an email to us directly. So the next thing we wanted to just talk about was an EISF pilot. So we are piloting the use of an EISF for REMAP CAP in a number of sites. Oops, sorry, just go back. And we'll be evaluating its practicality and acceptability to sites over the next few months. And this is linked to the archiving of amendments. So we've received conditional approval from the REC to archive all previous amendments if the EISF pilot is successful. So we'll confirm when these can be archived, and more details will follow via email communication from the management team. As you saw earlier on the website, we will be holding monthly Q&A sessions during the influenza season. So these will be drop-in sessions, and they'll be focused on different topics such as consent, Spinnaker, and any suggested sessions from sites. So the next part that we'd like to go through is monitoring, and our colleague from ICNAC kindly recorded this for us. So I'll just click play.
Hi, I'm Walton. I just wanted to highlight a few things about REMAP CAP monitoring. So REMAP CAP has central, remote and on-site monitoring. We will be prioritizing on-site visits for sites who recruited since December 2022, focusing on high risk and high recruitment. There will be separate visits for ICU, ward and paediatric teams. We aim to arrange the first site visits after the first 3 patients are recruited or within 6 months of first randomization since December 2022. For sites which haven't recruited since then, we will prioritize remote monitoring. During the monitoring visit itself, the main things I will be looking at are the consent forms and consent process, source data verification of selected patients, which will let you know beforehand, the ISF, and pharmacy if time permits. Based on the monitoring visits that we've done so far, these are the top 5 queries that we've seen. The consent process and documentation. Please make sure that any discussions with the patients, their personal legal reps or professional legal reps are documented in their medical notes. Data entry timelines. Since REMAP CAP is an adaptive trial, please make sure data is entered as soon as it can be, prioritizing the discharge, day 90 or daily forms, because these usually have the outcomes that REMAP CAP is looking for its adaptive response. SOFA scores and PTF ratios. So these are frequently mentioned by sites as being quite tricky. So to help with this, we made a calculator which will be soon releasing on our website. And hopefully going forwards, it should be a lot easier. Yellow banner queries. If you log into Spin and look at the home page, you'll be able to see which patients have yellow banner queries. These might relate to protocol deviations, which could be permitted or not permitted depending on what's specified in the protocol, but could also be to do with another type of data entry error. So for example, with organ support, if there's a discrepancy between what's entered on the daily form versus what's entered on the eligibility, baseline or discharge forms, this might flag a yellow banner query. Also, if the patient state changes from when they were assessed for eligibility to when they were randomized, for example, if they're no longer on organ support when they're randomized and they've been randomized, then please do let us know by email. Finally, the difference in criteria for high flow. So high flow to count as organ support, for example, on the discharge form is different for high flow to be noted on the daily forms, where it just has to be high flow. So to be on the discharge form, it needs an FiO2 of at least 0.4 and a flow rate of at least 30 liters per minute. However, on the daily form, so long as the FiO2 is greater than 0.21 and the flow rate is at least 20 liters per minute, then that's fine to be noted as high flow.
Perfect. So that is all. And if there's any questions, please do let us know either in the chat or you can raise your hand. And again, our email addresses are just at the bottom. So the first one is the UK management team. The second one is the sponsor. And again, the website link is just below.
Thanks, Liz. Maybe you could stop sharing. And just to add some of that monitoring, we're looking at, particularly as I said, we're being inspected by the MHRA at the moment, still ongoing. And so some of the feedback we've had from them, I think we all recognize in COVID, like it was hard to document everything. But it quite clearly is important that we document why we do things. So if you tried to speak to patients and they didn't have capacity, it's good to write that down, because sometimes the MHRA inspectors will come and say, but the patient was on the ward, why didn't you go and get retrospective consent? And you can say you went, but they still were delirious, for instance. That may not be recorded in the notes, and they wondered why we didn't get retrospective consent, the consent to continue. So please document it. Just although I don't know the teams who have joined, how many of your ICU and how many are ward-based teams, just things like daily organ failure scores and PF ratios and so on, that's only for ICU patients. That's not for the ward patients. There isn't any of that sort of more detailed data collection. We think it's important for the critically ill patients. These are fairly standard things that I think we all want to see for in the ICU. But for the ward-based patients, the CRF is much more simple. It's a dynamic CRF. It doesn't ask you, hopefully doesn't ask you questions that you don't need to give the answer to. So on the ward, it just literally says, when did oxygen therapy start and when did it stop? We don't ask on a daily basis, for instance. So that was some of those points. And I would say Obviously, with the CRF, there is what we call grey text around that, the sort of data dictionary. There's completion guides, but also you can see information about what sort of information is collected. So do look there for that information if anything is not clear. So that's the end of our presentations.